Yep. Thank you, Dr. Bhargav, for my introduction. And then I'm going to talk about has Compass changed the management of CAD? And would like to thank Delhi CSI for giving me the opportunity. And it's very aptly known, this session, that hitting the sweet spot. And let's see whether the rivaroxaban use after this Compass is hitting the sweet spot or not. What we know is that the current medical vascular protection today comprises of four pillars. And as we say that, what we mean that after the lifestyle modification, it mainly focuses on lipid lowering, blood pressure control, antithrombotics, and now we have some evidence from various glucose lowering drugs also like SGLT2 inhibitors, GLP-1 RAs, which are shown to modify the outcomes in patients of coronary artery disease. What I'm going to focus today is there a scope of improvement with current antithrombotic regimens? And I'm trying to show you some evidence with that. So what do we know as of now? What is the evidence in patients of CAD? Do they have recurrent MACE? And the biggest issue we face in patients who already have coronary artery disease is persistently high risk of MACE. And number of studies, if you look here, REACH registry, and what it looked at was the 4-year incidence of MACE in patients with prior ischemic events and without prior ischemic events, and you see the difference. You see that these patients have increased MACE. And similarly, if you look at the 3-year adjusted cumulative risk of all these events registry, 1 year post-MI, and this is from France, US, Sweden, England, and again you see that the risk of events increase. And in the Sweden post-MI registry also, you had a similar outcome. And the post-ACS in 52, we also have similar evidence from various trials which have been conducted with diabetes. So is the antiplatelet therapy which is being given, is it sufficient for chronic coronary artery disease? Up till now, we have evidence for aspirin, but which has been primarily based on a very old trials and when the other drugs were not there. And we know that the single antiplatelet is usually not enough except for a very small subgroup of patients of the chronic coronary syndrome with isolated CAD and who do not have previous ACS or any of the interventions and no other moderate or high risk features. So in those patients, probably aspirin does work well. And how does clopidogrel fare? And there was a trial by the name Capri in which clopidogrel was shown to be marginally superior to aspirin. And we have more potent now P2Y12 inhibitors when given as monotherapy. They do not reduce ischemic events, but reduce the bleeding compared to the other agents. And in chronic coronary artery disease, we know that it is not just the platelet activation, but also persistent thrombin generation, which needs to be addressed. So should we just intensify the platelet therapy, or should we look at some other ways also, maybe targeting the thrombin generation as one of the outcomes? And this is evidence from another study which looked at the residual risk, that is despite patients being on guideline-directed medical therapy. And if you look here, that about 96.5% patients were on ASA and about 88.4% patients were on 2Y12 inhibitors, about 95% patients on statin. So well-treated group of patients. And what you see here is the event rate, which increases over a period of time. And if you look carefully, you see that the risk is greatest in the first 3 months, and then it continues to increase later on. So what are the options in our high-risk patients? We know that there are various drugs which have formed the backbone of therapy. Now, in patients who are at a high risk, like post-myocardial infarction, more than 65 years, diabetes, recurrent events, or multiple vascular bed involvement, should we focus on DAPT or the dual antiplatelet inhibitors? We already know about the role of coagulation pathway also in the atherothrombosis. It's not just the platelets. We know thrombin is the most powerful platelet agonist. We also know that fissured platelet thrombosis initiated by tissue factor and coagulation plays a big role in acute coronary syndromes. Also, the anticoagulation fibrinolysis does have a role in inflammation. The hemostatic predictors of MACE are mainly coagulation based and not platelet based. And we also know that coagulation, not platelet gene variants, are predictive of arterial thromboembolism. So, given this background, we know that if we use a dual pathway of inhibition, that is, we use rivaroxaban with aspirin, both platelet activation and thrombin generation can be targeted in patients of chronic coronary artery disease and PAD. And if you look here, the rivaroxaban acts on thrombin by factor 10 inhibition, and it also prevents generation of PR1 and COX2 by the PR4. And when given with aspirin, both the pathways are targeted and it prevents the atherothrombosis. So rivaroxaban impacts not just the fibrin, but also the platelet activation. So given this background, the COMPASS trial was done, and it was looked in patients of chronic coronary artery disease and peripheral arterial disease. And the investigations were stopped 1 year ahead of expectations due to overwhelming efficacy of this combination. And I'll just give you a brief background that about 27,000 patients were in this study, and about 91% patients had chronic coronary artery disease, 27% patients had peripheral arterial disease, and there were 3 arms, rivaroxaban 2.5 plus aspirin 100 and rivaroxaban 5 and aspirin. The average follow-up was about 23 months at the early termination of study. And it included patients who were at a high risk of MACE or of major adverse limb events. And what it included was patients aged more than 65 years or through sclerosis in more than 2 vascular beds. If the age was less than 65 years, they should have had 2 additional risk factors like smoking, diabetes, EGFR being low, heart failure, or prior non-lacunar ischemic stroke. So all these things we know predispose patients to the recurrent events. And look at the results. What you see here is the dual inhibition, pathway inhibition by rivaroxaban and aspirin significantly reduced the incidence of CV death, stroke, or MI. And here you see that the cumulative evidence with aspirin, with rivaroxaban alone, and also 5 milligram BD, and also with rivaroxaban 2.5 milligrams plus aspirin, you see a relative risk reduction of 24%. And you look at the p-value here with this combination was significant. This was quite significant, in fact. And what are the clinical implications of this? The clinical implications for this trial are that coronary artery disease patients and peripheral arterial disease patients, who are at a high risk of atherothrombotic events, the dual pathway mechanism can overcome these limitations. And what about the bleeding risk? We saw that they almost had a similar rates of fatal and intracranial bleeding as was observed with aspirin. Now, what COMPASS showed was that it was clearly superior to aspirin in reducing the composite of CV death, MI, and stroke. It also showed a high absolute risk reduction in the high risk group, and the net clinical benefit was seen prevention of secondary CV events in patients of coronary artery disease. And this benefit increases over a period of time. It was applicable to broad category of coronary artery disease population who is at a high risk in our routine practice. And what it showed was a reduction in MACE to the tune of 26%, stroke 44%, CV death 25%, and all-cause death by about 23%. So should the DPIs replace the DAPT to prevent MACE in chronic coronary artery disease? So we have some evidence from various trials. So I'd like to show that in light of that. First, earlier trial with clopidogrel alone, it showed a reduction in MACE of about 9 and reduction in CV death by 8, and major bleeds were about 27% less. So this showed a relative superiority of clopidogrel. The Charisma trial, clopidogrel plus aspirin, did show a reduction of MACE of about 7. And what it showed was gusto moderate bleeding of an increase in about 60%. So whenever you have reduction of MACE by dual antiplatelet, you have increase in the bleeding risk. So with Pegasus 90 plus aspirin, what it showed was a reduction in MACE by 15%, but a T major bleedings more by 160. And after 1 year, when the ticagrelor 60 milligrams was used with aspirin, similar reduction of about 16%, but again, the TB major bleeding was not eliminated, was still 132%, although less than 160. And this led to propagation of use of ticagrelor 60 plus aspirin following the Pegasus trial. We recently have another trial in which the ticagrelor has been used, the THEMIS trial. And in this trial, you see a 10% reduction in MACE, but what you should also see is again 132% increase in the TIMI major bleeding. So as compared to ticagrelor 60, Pegasus, and THEMIS, you do see a reduction of MACE coming at the expense of increased bleeding. And what did the COMPASS show? COMPASS showed a quite significant reduction in MACE to about 24%. And what it showed was that the modified ISTH bleeding rates of about 70%. This also doesn't come at the expense of reduced bleeding, but it's much less as compared to the other dual antiplatelet agents. And the MACE events are much less compared to the other drugs. So it is the only antithrombotic regimen which has been shown to show significant reduction in the all-cause mortality. So where does this place us now? The guidelines are now changing. In fact, 2018 guidelines on myocardial revascularization did recommend about the DAPT 6 months stable PCI and more than 12 months in patients of ACS 1A. And what it also talked was more than 12 months in low bleeders and 1 to 3 months if stable high bleeders, and the indication was 2BC and 2AA. The 2019 guidelines for management of chronic coronary syndromes, what do they recommend is that adding a second antithrombotic drug to aspirin for long-term prevention should be considered in patients with high risk of ischemic events and without increased risk of major or life-threatening bleeding. And the class is 2A and the level of evidence is A. It also recommends adding a second antithrombotic agent to aspirin for long-term prevention may be considered in patients with moderately increased risk of ischemic events. So both in high risk and in moderately increased risk of ischemic events, we can consider adding a second antithrombotic agent based on the guideline class and the level of recommendation. 2A for this and 2BA for the moderate increase in ischemic events risk. What about the non-STEMI ACS guidelines? We also have some data from Atlas STEMI 51 in which the patients of ACS were given rivaroxaban, and also we have evidence now. The latest guidelines do recommend that for non-STEMI ACS, adding a second antithrombotic drug to aspirin for long-term secondary prevention should be considered in patients with a high risk of ischemic events and without increased risk of major or life-threatening bleeding. And again, it's class 2A level of evidence, and for moderately increased risk of ischemic events, again, we have recommendation of 2B and level of evidence of A. So we have multiple options today to treat our chronic coronary syndromes. We clearly know that in high-risk patients, the aspirin is not enough. So what should be added to aspirin? Should we add clopidogrel? Well, we can use it in post-MI patients who have tolerated DAPT for more than 1 year. Prasugrel, again, we must use it in patients post-PCI for MI patients who have tolerated it for 1 year, but there is a risk in patients with age more than 75 years. You should be careful. It can cause more bleeding. And if you look at rivaroxaban, it can be used post-MI 1 year or multivessel CAD. And the caution is to be in patients who have creatinine clearance less than 30. What about ticagrelor 60 milligrams BD post-MI patients who have tolerated DAPT for 1 year? Again, you can use it. But what we know is rivaroxaban is the only option, dual antithrombotic therapy, which is indicated in patients with chronic coronary syndromes at high risk and with or without prior myocardial infarction. So having said that, the outcomes are there, and probably targeting the DPI instead of just targeting the dual pathway inhibition instead of increasing the antiplatelet could be leading us to a way forward. As we have been using COMPASS to show us direction, probably this COMPASS trial is showing us the direction to move about in managing our patients of chronic coronary syndrome. Thank you so much.
Can I have a question?
Yeah, sure.
So why not a combination of clopidogrel plus rivaroxaban 2.5 milligram twice daily? Because Capri has clearly shown that clopidogrel is superior, it doesn't cause a GI bleed, and is equally or even more effective in preventing stroke and peripheral vascular disease. So why not combine clopidogrel plus your rivaroxaban 2.5 twice daily?
Yeah, I get it, Dr. Yadav, but the only thing is it's not been studied in a big trial. We do not have any trial evidence which is based, which has been tested, the hypothesis made, and been tested in such a large trial. We have evidence of aspirin with rivaroxaban, and until and unless we don't have evidence, we cannot have it in guidelines, and probably we'll be a little hesitant to use it.
Do you think any trial is going on?
No,
plus rivaroxaban 2.5 milligram?
No, I'm not aware of it. No, I'm not aware of it.
Okay.
I'm not aware of it. Neither it's available.
Combination. It's justified combination. Aspirin has many side effects, which is not with the clopidogrel, and you will have a benefit with the Capri. Is even bleeding risk is less, 27% less, which you already showed. So why not to combine clopidogrel?
So once the trial comes, then we will consider combining. There's no trial as of now.
But justified.
No evidence.
That's
although what you say has a logic, I fully agree with that, but then it has to be shown in the evidence, in the trials.
Thank you, Dr. Ashwani, for a wonderful presentation.